Thank you very much, Dr. Sandeep, and all the team here for having me here. We'll go to the talk. We don't have much time. So greetings to you all from Rajiv Gandhi Cancer Institute, Rohini, Delhi. I'll be talking on surgery after NSCT in locally advanced lung cancer. It is surprising a surgeon is going to talk basically about the role of systemic treatment, before surgery, but that's the reality now that surgeons, we understand the importance of systemic treatment, because despite doing a very, very good surgery, we have a lot of recurrence at the end of 4 years, 5 years down the line. And the coming of newer agents has definitely changed the perspective. And I think we'll be operating more and more cases of locally advanced disease because of this. So first, NSCT, in terms of chemotherapy, we know it's basically that's given a systemic treatment before the main treatment, which is surgery. And the goal is obviously to do R0 resection, because once you achieve R0 resection, that's how all the prognostic factors improve. So indications, in short, resectable and 2 nodal diseases are the ones which go for pre-op NSCT, and potentially resectable central tumors, wherein, because of its proximity to the vessels, to nodes, you might have some injury and maybe come out with a pneumonectomy rather than doing a lobectomy, which you always want to avoid. And we need to know that it does not make a lesion which is unresectable as resectable. This is very, very important. And for other things, it is not really established whether this is a role or not for those resectable lesions involving the chest wall or ribs, the diaphragm and pericardium, which can be easily resected with impunity. So I leave this to debate, and it will depend from center to center how we approach this. So locally advanced, in short, it's basically bulky tumor size, more than 5 or 10 centimeter, involving adjacent structures which are resectable, and obviously metastasis to the nodal stations, that's N1 and N2, and N2 is the specific site we are talking presently. So last 30 years has all been about the pre-immuno era, and adjuvant or no adjuvant NSCT for resected NSCLC has improved the OS by just about 4 to 5% at 5 years. And meta-analysis of the cisplatin-based induction has shown that it causes a 13% reduction in death, and absolute survival in whatever terms in meta-analysis everywhere you see it's just about 5% increase. And if you see all these sort of clinical trials for 3A, it's just about 34% 3-year survival. And from high volume centers like MD Answer, MSKCC, it's higher, something about 40% at 5 years, which in today's scenario is very, very suboptimal, given the coming of the Pacific trial, the result, which has definitely made the surgeons have to rethink a lot about this, because for unresectable stage 3 disease, they are claiming now at 5 years about 42%. That's because of the magic of immunotherapy, I think so. And I think we have to accept that. So in the pre-immunotherapy area, the predictors, classical predictors of long-term survivals, we all know again, are R0 resection, downstaging is also one important factor. PAT-CR, pathological complete response, is something we are now always talking about. And obviously the major pathological response, which is a very, very common term in the new immunotherapy era. That's when less than 10% of residual tumor are left behind. And it is being used as a surrogate for OS, overall survival, in the immunotherapy area, though it is unproven in any RCTs that it is can be used as such, but this is what we have at the moment because of the long time it takes for maturity of data. So in the pre-immunotherapy era, if you see, this is the data of the PAT response, pathological complete response with chemotherapy, it just goes to maximum about 20%. And with now we come to the immunotherapy area. I would like to just say in terms of it can be used as neoadjuvant, as single agent, combined with chemotherapy or dual immunotherapy. So now we have got various, numerous phase 2 and phase 3 trials going on, and some have been published also. So if you can see here, this is the phase 2 neoadjuvant immuno trial, and the SAC trial is something we can talk about. The Nadim study is obviously very, very, very encouraging. We've been hearing about it, and there are other numerous which I will not really elaborate because of the lack of time. And the phase 3, we have now basically the CHECKMATE 816 recently it has come, basically use of atezolizumab, and they've seen the MPR and EFS as endpoints. And again, is still yet to come. We have been participating in that, and we expect the result. So currently, the neoadjuvant IO trials are basically focused on resectable NSCLC, and the phase 2 NADIM and phase 3 CHECKMATE 816. I will just go to it to highlight the importance of it. NADIM phase 2 is a single arm, open label, multi-center, wherein neoadjuvant IO and chemotherapy versus chemo was compared, followed by surgery, and again continuing of adjuvant IO. This was basically for resectable stage 3B multi-station N2 disease, where they found that the primary, they look at the primary endpoint, the PFS at 24 months was 66% compared to 42%. Secondary endpoints at OS at 3 years was very encouraging, 84% versus 63%, that too in stage 3A multi-station N2 disease. Phase 3, the CHECKMATE, which was recently published, and we all know very well, it was again for resectable NSCLC, which showed the benefit of neoadjuvant IO and chemo for our standard chemotherapy. It was again for stage 1B and 3A, 358 patients, surgery post-randomization. We see that 83% of the patients could proceed to surgery post-chemo and IO versus 75% who received chemo only. The R0 resection rate was also quite high, 83% versus 78%. And the primary endpoint at present we know about PCR and event-free survival is about, for PCR it's 24% versus 2.2, and for event-free survival it's about 31.6 months versus 20.8. This is just a schemata of basically how the IO acts in the neoadjuvant setting and the adjuvant setting. In the neoadjuvant setting, because more tumor cells are there, they are exposed to it. So you have activations of more different type of T cells, which basically, once the tumor is removed, and there are more diverse T cells which search for tumor cells in the systemic circulation, and that's how it theoretically looks much better. And the role of adding chemo during neoadjuvant also has been proven in some translational study. It's like increasing the PDL1 plus tumor cell response, immune infiltrates are increased, and also it has got a synergy effect with immunotherapy when you add chemotherapy. Presently, what's the rationale for neoadjuvant in the immunotherapy era that we are presently? Biological efficacy, if you see, in the NADIM study, we saw a pathological complete response of 63%. In CHECKMATE, it was PCR of 24% versus 2.2%. In terms of compliance, the IMPOWER, it is basically an adjuvant IO. The compliance was basically 65%, and the rest in the neoadjuvant setting, the CHECKMATE and NADIM, it was about 94% and 100% NADIM, which was multi-station N2. And they all had effect on downstaging. They increased the R0 resection rate, and CHECKMATE 816 proved it to be effective, safe, feasible, and acceptable surgical delays and adverse events. So next question comes, when do we do surgery of neoadjuvant chemotherapy? For stage 3A in the NSCT setting, we know that it should be done within 6 weeks. Then anything done beyond 6, when you prolong it, it tends to decrease the survival. For NSCT and IO, it's ideally do a 3 to 6 week period. This is what the present all studies are doing it. And delay has got a potential for tumor repopulation, distant metastasis, anatomy change at the local site, which is very, very important for the surgeons because that site gets fibrosed, that tissue planes get thickened, so the surgery becomes more difficult. So, and we need to understand immune flare, a new concept which has come with the neoadjuvant setting, in that we see radiological changes of nodal progression. The nodes increase in size, video biopsy, they come as granuloma or a sarcoid-like immune remediation. They are basically pseudo progression, and such cases should not be deemed unresectable, but should be proven pathologically as being a pseudo progression, and they should undergo curative resection. Surgical implications in the real world, surgery is going to be more challenging, and we need to stick to this time interval well in advance by the time of counseling that this is a protocol. We need to have a surgery at a specific period of time, because if not, the surgery becomes more and more challenging. And I would like to conclude by saying this, that advances in chemotherapy and immunotherapy, the addition of immunotherapy, surgery is going to create a more greater role in advanced disease, and we'll have more and more curative intent in mind. As surgeons, we should embrace the concept of neoadjuvant immunotherapy more and more. We'll see more and more survivals. That's what I expect. And very important, like we talked about it, biomarker testing is very, very essential. And because a biomarker-driven tumor is not going to respond to immunotherapy and vice versa, so it's very important we do a biomarker test in all such cases. And for stage 1B and 3A, those who are biomarker negative, it's obvious that neoadjuvant and immunochemotherapy will be the preferred option in the coming times. Thank you all very much. I think I spoke exactly time.
How does the
as you've seen, I showed you that immune flare system is there. So it's basically a reactive thing. So when anything reacts, you can see the tissue planes become less separable. So the cell become more challenging because you're basically working in a high area. You need to do a lymph node dissection also. And lymph nodes typically sit on the pulmonary vessels. So this is how the cell becomes more challenging. Yes, not exactly that the fibrosis that you see in radiation, but something like that. The tissue edema. The plane doesn't come off easily. In the natural anatomy, everything comes off smoothly. You just touch it, lift it, it comes off. Just like you call a Jhaksa layer is there between the nodes and vessels, but you will not get that layer here. Post-immuno. Yeah, we are involved with the EGAN trial. Yeah, if you stick to the timeline, because it was a protocol study, so we stick to the timeline. There was a little bit of difficulty, but it's not something undoable. You need to be more careful, basically, because we are still in the process of learning. And as I told you, lymph node is very important in part of the surgery, and lymph nodes always sit under pulmonary vessels. Can you repeat the question? Because the planes are not well developed. Yes, you can have pulmonary artery bleeds, pulmonary vessel injuries.
Whenever I look at the data, because this is a concern, few of my friends also addressed that post-immunotherapy you may have more fibrosis and the planes may not be there. But when we look at the data of Nadim-2, which is a randomized trial, we look at the data of CHECKMATE 816, actually the adverse event rates between both the arms actually are more in favor of the immunotherapy arm. So my concern is, do you think it's a function of the learning curve for the surgeons that 20 cases or 25 cases after that, there would not be this kind of way? Because whatever that you are told is correct, and I have got this feedback from one or two more surgical friends of mine. But when you look at the data for the adverse event rate, that actually goes in favor of that you give immunotherapy first.
Yes. The CHECKMATE study, in fact, showed that the rate of pneumectomy was less in the immunotherapy arm compared to the chemotherapy arm. I think it's basically got to do with the learning curve. The more you get exposed to it, definitely, it will be. And if you stick to the timing, that's also, I think, very, very important. See, in the CHECKMATE study, they have not found any significant increase in complication with the immunotherapy arm. But this is basically our personal experience. If you ask any surgeon, they will say that post-immunotherapy, the planes are definitely more difficult, more challenging. Thank you. Yeah, thanks.
So thank you, Dr. Darlong, sir, for such a lovely presentations and answering a few of the questions. So we moved on to the